When a pericardial effusion is large enough or happens rapidly enough, this can lead to significant decreases in cardiac output and blood pressure, leading to severe shock. This is a life-threatening emergency that requires prompt recognition and management in order to save the person's life. In this lesson, we're going to look at what exactly cardiac tamponade is and how we manage those patients in the ICU. Alright, I welcome you guys back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my goal with this channel here is to try to give you guys the confidence to succeed in the ICU by taking these complex critical care subjects and making them easy to understand. I truly hope that I'm able to do just that. If I am, I do invite you to subscribe to the channel below. Make sure you hit that bell icon though, that way you never miss out when I release a new lesson. Now also, if you do enjoy these lessons and you'd be interested in getting CE credits for following along with them, then head on over to icuadvantage.com/academy and join the ICU Advantage Academy, where you can watch all these videos. You'll have access to all the notes, including the new notes that I'm currently working on updating, as well as audio-only versions of these lessons. And most importantly, you'll be able to actually earn CE credits for participating in this education. So I've got some great deals going on over there, so make sure and check that out. Now, if you would like to support the channel but really don't have a need for the CEs, or if you just want access to things like the notes, then you might also want to take a look at either the YouTube or Patreon memberships. Again, links to both of those. All that stuff is going to be down in the description below. Okay, so in the last lesson, we did a good deep dive into a pericardial effusion, what it is, the pathophysiology behind it, and some of the management strategies for those patients. In this lesson, I'm not going to cover the anatomy and pathophysiology of a pericardial effusion in general, so if you need a refresher, please watch that lesson that I linked to up above. Instead, in this lesson, we're going to focus specifically on the life-threatening progression of pericardial effusion to cardiac tamponade. It's vital that you're able to recognize this early, as these oftentimes progress rapidly and the patient can quickly deteriorate. Okay, so let's start things off and quickly cover the pathophysiology of what's happening in cardiac tamponade. So as mentioned, this is the result of a pericardial effusion. If a pericardial effusion is either so large or it happens over a short period of time that this can lead to an increase in pressure on the heart or the intrapericardial pressure. As described in that last lesson, the pericardial sac is generally a constrictive sac that's around the heart. If an effusion develops slowly, it can stretch to accommodate potentially large volumes of fluid. But if that fluid accumulates rapidly, the pericardium is not going to be able to stretch to accommodate that. You can almost think of this like leather. If you have some leather shoes that over time they eventually stretch and conform to your foot, but that doesn't happen very quickly. In a rapidly accumulating pericardial effusion, even as little as 50 or 100 mL of fluid can lead to cardiac tamponade. Now, remember that there is a relationship between volume and pressure that's one of the primary laws of physics. If we increase the volume in a confined space, we see the pressure increase with that volume increase. Now, this holds true inside the pericardial sac. If the volume in there increases, especially rapidly, then the pericardial sac is not going to stretch to accommodate, therefore we see an increase in intrapericardial pressure. Now, the right ventricle is the weaker, thinner-walled chamber, and this increase in intrapericardial pressure can actually compress that RV. This leads to decreased filling, and then backup of blood returning to the heart, and thus decreased forward flow of the blood to the left ventricle. In addition, this pressure from the compressed RV also puts pressure on the intraventricular septum, which then compresses the left ventricle some, leading to decreased left ventricular filling volume. Combined together, this can lead to decreased stroke volume and thus decreased cardiac output for the patient. As tamponade progresses and the fluid and pressures increase, the end diastolic pressure of all four chambers is going to begin to equalize as they really can't relax enough due to that intrapericardial pressure. So now, when the body experiences decreased cardiac output, it's going to attempt to compensate for this, and these are the compensatory mechanisms that we see. To understand these mechanisms, we need to remember the components of cardiac output. So we have our equation, cardiac output equals heart rate times stroke volume. And stroke volume is impacted by preload, contractility, and afterload. Now, our primary driver of these compensation mechanisms is through the release of catecholamines, most notably epinephrine and norepinephrine. When stroke volume is decreased from decreased filling of the left ventricle, the first and most noticeable compensation that we're going to see is in the patient's heart rate. If the stroke volume is low, the heart rate must increase to make up for that, which can manifest itself as tachycardia. Remember, though, that this only works for so long, and the faster the heart rate, the less time to fill during diastole, and this can actually further worsen the filling problem seen in tamponade. Now, if the patient's blood pressure lowers as a result of decreased cardiac output, then the body is going to attempt to increase SVR to maintain proper blood pressure. This is again mediated by those catecholamines, and while in the short term this can help to increase blood pressure, this is also increasing afterload, which decreases how much volume the heart can eject, lowering the stroke volume. Now, the catecholamine release will also help to increase contractility, working to increase stroke volume as well. Now, in order to increase preload, the last component of stroke volume, the body's actually going to activate the renin-angiotensin-aldosterone system, or the RAS system, to hold on to sodium and water, increasing blood volume. While the goal is to increase volume and preload, in cardiac tamponade, this volume must overcome the intrapericardial pressure and is often minimally effective and can further worsen edema and congestion. So remember that these compensatory mechanisms are only temporary, and if the pericardial effusion is not reduced, and especially if it continues to grow in size, that this can lead to hemodynamic collapse, shock, organ failure, and even death. All right, now that you understand what's happening in tamponade, let's now talk about some of the signs and symptoms that you're going to see in your patient. Again, it's imperative that you're able to recognize these signs and symptoms early to be able to intervene early for these patients. So the classic sign of cardiac tamponade is something that we call Beck's triad. This is a collection of 3 signs that together are a strong indicator of cardiac tamponade. They are hypotension, and this is the result of low cardiac output and that ineffective compensation; jugular venous distension, which is due to the backup of blood returning to the heart, and we'll see enlarged neck veins; and then muffled heart sounds, and this is as a result of the fluid around the heart, that this can lead to more insulation, and thus the sound of the heart tones are not going to escape as easy, making them quieter or harder to hear. All right, next we have tachycardia, and this is one of the earliest signs that you're going to see in your patient as their body attempts to compensate for that decreased cardiac output. Remember that this can be masked in patients, though, who are taking beta blockers. Now, if you notice a persistent or increasing tachycardia, especially combined with hypotension, recognize this as a compensatory response to decreased cardiac output. A lot of times this is going to have you thinking bleeding in patients, but especially those who are at risk for pericardial effusion, you also want to be thinking of tamponade. We're also going to see dyspnea and orthopnea in our patients, so they can become short of breath. And this may be the result of pulmonary congestion, and if so, crackles are going to be able to be auscultated. This may also be the result of the enlarged mediastinal space that's putting pressure on the lungs. And this is often especially noted in patients lying down, aka orthopnea. Now, if your patient has an arterial line, you can notice pulsus paradoxus, or an increasing and decreasing baseline for their blood pressure that aligns with their respirations. So this is really defined as greater than 10 millimeters of mercury in difference between the high and low, like I said, that occurs with respiration. So this is the result of changes in intrathoracic pressure during breathing. Now, on inspiration, intrathoracic pressure decreases due to the lowering of the diaphragm. This allows for better venous return and greater filling of the right ventricle, which actually shifts the intraventricular septum a little bit to the left into the left ventricle. Now, in normal patients, the left ventricle can shift to accommodate this shift in the interventricular septum, and little to no effect results from this. Now, in tamponade, the left ventricle can't shift over, and thus we see a decrease in left ventricular filling, and thus a decrease in stroke volume, cardiac output, and thus blood pressure. Now, on expiration, this flips. There's less filling of the right ventricle, the interventricular septum shifts back to the right, increasing the left ventricle filling and thus its output. Now, like tachycardia, this can actually be another early sign to recognize for patients that have an A-line. And one other thing to keep in mind that this is for spontaneously breathing patients. If you have a patient who is on the vent with positive pressure ventilation, this whole process actually flips. We would actually see an increase on inhalation where that positive pressure decreases the venous return to the heart, thus increasing the left ventricular output. Now, real quickly, here's an example of two arterial line tracings. The top one here, this is normal with just some slight variation in the pressure, while on the bottom you can see the increasing and decreasing pressure as a result of those respirations. Now, if your patient has a SWAN or PA cath, there are a few things that you can notice there. So there is going to be decreased cardiac output, and so whether this is with a continuous cardiac output monitor or you're doing the bolus cardiac output calculations, you are going to see a decrease in cardiac output and cardiac index for these patients. You're also going to see increased CVP as well as occlusive pressure or pulmonary artery diastolic pressure. And due to the decreased forward flow of both the left ventricle and the right ventricle, we're going to see blood backing up, leading to increases in those numbers. And also you're going to see an increased SVR. So as the body attempts to compensate for the low blood pressure, it's going to attempt to clamp down on the blood vessels, leading to increased SVR, which can be calculated with a PA cath. So some other clinical signs that we can see, you've got weak, thready pulses in these patients, delayed capillary refill. You're going to see pallor as well as cool, clammy skin, especially if they've really progressed to that point of shock. And then you also can potentially see something called Kussmaul's sign. And this is not to be confused with Kussmaul's respirations. This is actually when you see an enlargement of the jugular veins on inspiration. Okay, so far we've talked about the pathophysiology of what is happening in cardiac tamponade, as well as the signs and symptoms that you'll see in your patient. Now let's talk about how we diagnose this. So a transthoracic echocardiography, or echo, is going to be the gold standard for diagnosing cardiac tamponade. That said, in an emergently and rapidly developing tamponade in an unstable patient, a bedside point-of-care ultrasound can also be very beneficial. Some of the hallmark signs are fluid accumulation in the pericardial sac, compression or collapse of that right ventricle, dilated IVC from the impaired venous return, and then a swinging heart within the pericardial fluid. Now on ECG, we can also see low voltage due to the increase in fluid around the heart. Tachycardia is something that we're going to notice on ECG as well. And while rare, we can also see electrical alternans, as you can see in this example here, where you've got the increasing and decreasing amplitude of the QRS complex. And here, due to the swinging of the heart, it changes the conduction of impulses out to our electrodes, which is what gives us this pattern here. And then when it comes to a chest x-ray, if the pericardial effusion is large enough, so typically at least 250 mLs, then you can see an enlarged cardiac silhouette on chest x-ray. A lot of times, though, this is going to be more diagnostic of those larger chronic large effusions. And then, as mentioned in the last lesson, CT may also show the effusion as well as some other signs of tamponade, but this is not really a diagnostic tool that we want to use if we suspect tamponade in our patients. Okay, and now finally, we need to talk about how we manage these patients with tamponade. So I cannot stress this enough. Remember that this is a life-threatening situation for your patient. Oftentimes, your patient is going to decompensate quickly, and it can really get chaotic with these patients, so it's really helpful to know what to expect, what to do, and really how to prepare for what's next. These are unstable patients, and they need rapid resolution. So for these patients, the most immediate intervention needed is the draining of fluid around the heart. Most of the time, this is going to involve a pericardiocentesis, which, as I discussed in the last lesson, is the insertion of a needle, oftentimes with a catheter, into the pericardial sac to drain the fluid from around the heart. Now, this can be done by landmarks or more preferably with ultrasound needle guidance. Remember that in small, rapidly developing effusions, even the removal of a small amount of fluid can really make a significant improvement in these patients. Now, this is not a fix to the problem that led to this effusion, but really this is a temporizing measure to return the hemodynamic stability back to these patients. So you want to gather all the necessary supplies, sterile syringes, needles, catheters, as well as having the ultrasound in the room if you have it available. Now make sure that you've got good IV access both for meds and or fluids, and then be ready to assist the provider with the procedure. In emergencies, especially arresting, penetrating chest traumas, an open thoracotomy is actually the preferred method here. This involves opening the chest via thoracotomy, exposing the heart, and then opening the pericardial sac to drain the fluid around the heart. Now, in blunt force traumas that lead to hemopericardium, that these are generally not survivable, and thus an open thoracotomy is typically not advised for these. Now, in post-cardiac surgery patients, they may be rushed back to the OR, or if severe enough or declining enough, actually a bedside re-exploration and drainage by reopening the sternum and undoing those sternal wires may actually be needed. In these cases, make sure and alert the OR team immediately, regardless of if this is going to be bedside or not. They're going to come bedside if it is. Make sure you grab the chest re-exploration cart or trays or whatever your unit has. Again, make sure you've got good IV access for meds and fluids and blood if you need it. Prepare the room by removing all unnecessary things. You want to quickly declutter. This way they can set up sterile fields, have room to work, kind of inside this mini operating room that they're going to set up inside your room. Now, if you are going to the OR, make sure you've got all the necessary emergency supplies and meds and fluids and things to bring with you as you take the patient pretty quickly. Now, while you're awaiting this immediate intervention and if your patient's continuing to decline, there are some supportive measures that we can do. So first, we have volume expansion. So we can give the patients fluids or blood to improve the blood volume and venous return. This is the primary means of supporting these patients while we await intervention. In addition, some inotropic support medications like dobutamine or milrinone may be considered, although these may also increase myocardial oxygen demand in an already decompensated patient. Now, when it comes to vasopressor support, typically vasopressors are not indicated nor helpful unless profound hypotension is present, and this is an attempt to provide some baseline level of systemic blood pressure while we're awaiting that definitive treatment. Remember that vasopressors increase SVR, so our afterload, which is going to be working against us in a decreased cardiac output state, as well as we have a filling problem, and so increased vascular tone is really not going to fix that. These medications may also increase myocardial oxygen demand in these low perfusion states. So again, fluids is our primary go-to for these patients, but if they are profoundly hypotensive, some vasopressor support may be needed while we're awaiting that intervention. Now, we also need to talk about chest tube management, specifically in cardiac surgery patients. So patients that are post-cardiac surgery are likely going to have mediastinal chest tubes in place. The output of these chest tubes can really be an early indicator of problems. If the output slows up or comes to a stop, this is a strong indicator of a problem, especially if your patient becomes unstable with decreasing cardiac output and blood pressure. Early on, you can actually sit the patient up into high Fowlers to try to reduce pressure on the heart as well as to help facilitate drainage out of the chest tube. You want to make sure and check the chest tubes all the way down to the atrium and ensure that that system is working properly, that there's no kinks or obstructions or anything present. And then you also want to make sure that the suction is on, it's attached, and that we have it set to the appropriate level. Also, based on your facility policy, you want to try milking and or stripping the chest tubes to help to remove any clots that may be slowing or stopping the drainage. Do be careful with this though, as if you are doing vigorous stripping, that this can actually cause damage to the heart and then lead to increased bleeding. So many of the interventions, as well as signs and symptoms, are still going to be present in these post-cardiac surgery patients that are developing tamponade. And remember that all of these interventions that we do are just temporizing measures while we wait for that definitive and immediate drainage of the fluid. All right, well, that about covers the topic on the progression of pericardial effusion to cardiac tamponade. You as the bedside nurse play a vital role not only in the early recognition of the signs and symptoms and the communication of that to the providers for them to act quickly, but also in those temporizing measures of supportive measures while we await that immediate intervention. Hopefully, after reviewing this lesson and the previous one on pericardial effusion, you have a little better understanding of what's happening with these patients, how you can identify these changes earlier the better, and your role in managing these patients before and during definitive treatment. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.